All right, so my name is Emma. I've had the pleasure of speaking with you guys a few times now. I recognize a few of your names out there. And really what we're going to do today, we're going to talk a little bit about lung cancer in this virtual rounds. I know that you guys are going to be pros at all things pulmonology. I know that you guys talked about COPD last week. We're going to talk a little bit more pulmonology in terms of lung cancer, a little more oncology. Is just curious, is anyone out there, I know we have a smaller group today, anyone out there interested in oncology, perhaps as a specialty in the future? Cool. Nice. So there's a couple of people, Jenna and Matthew, perhaps. Regardless, you guys and anybody else always keep your, an open-mindedness in terms of going into medical school. I will tell you that I thought I wanted to do pediatrics, and then now, I'm applying to internal medicine, which is, if you know anything about the two specialties, they're almost polar opposites. So keep an open-mindedness in terms of, what you think you want to do and what you actually end up, loving and wanting to do. Okay. So with that being said, let's see here. Let's keep it moving here. So as always, if you have missed any sessions, if this is your first time, that's okay. We record all of our sessions and they can be accessed online on YouTube. So we would love if you, hit subscribe. If you have any questions whenever you're watching this back recorded, no fear, put a, comment in the chat. We certainly look over those and monitor those and see if you guys have any questions. Or any comments at all, okay? For those of you that just logged on, here's some links for you. I just put that in the chat. And like I was alluding to, we are going to talk today about lung cancer. While lung cancer is not a joke, I think anything in medicine deserves a little bit of lightheartedness or otherwise, you're gonna have a tough time because it's gonna be very dark. And I saw this and immediately I was like, I have to put this into my my PowerPoint slides. So with that, let's go ahead and launch the pre-poll here. And now I didn't edit the pre-poll. I just went ahead and launched it. It should say lung cancer. So this is the same question I ask you guys all the time. Disregard the restrictive and obstructive lung diseases. That was from last time I taught you guys. So basically just put in your vote in terms of what you know about lung cancer. All right, I think most of you guys are in there. Let me share this with you. A little, it looks like a little is kind of the overwhelming majority. Some of you guys said you know nothing. That is definitely okay as well. And throughout the talk today, if you have any questions at all, please feel free to throw them in the chat. If you're more of the talking type and you want to talk to me, I would love to hear your voices and see your faces if any of you are feeling ambitious and want to turn on your cameras or turn on your mics and chat with me. All right, so let me stop sharing this and let's keep going because my goal today, and you guys can hold me accountable, my goal is to be on time and get you guys, going in an hour. I'm always notoriously gone over my time, so I don't want to continue to be that person. All right, so as always, if this is, regardless of if this is your first time, second time, 100th time, we are going to, we're gonna basically go through a full case about, our topic that we're discussing today. We're going to go through a physical exam. We're going to talk about case details. We're going to, go through differential diagnosis, assessment, and plan. Your guys' role, as always, be active, ask questions. No questions are dumb. I guarantee if you have a question, somebody else out there has, probably the same exact question. That's okay. All right, so for you guys to get credit for the session, fill out that SOAP note form that I just put into the chat. And that's really an acronym to stand for subjective, objective, assessment, and plan. And so here's the note here on the next slide. Subjective talks about things that the patient tells you, like the HPI and the ROS, HPI being history of present illness. So the kind of narrative, the paragraph that you write in the document, in the EMR, or if you're still handwriting things about what the patient told you. The review of system is pertinent positives and negatives that relate to the chief complaint. Objective is vital signs and physical exam findings. So those are things that are objective to us. We find them. Assessment and plan is what we think is going on, the differential diagnoses, kind of in correlation to the plan that we're going to do with those differential diagnoses, or what we think is going on. Okay. So, case. This is a 55-year-old male presenting with a 2-month history of cough and shortness of breath. He endorses that over the past month, he's lost approximately 15 pounds. He was originally 180. He notes that he's seen his PCP for cough, for which he was given guaifenesin, which is like Mucinex, just a cough suppressant, or to get the mucus up, essentially. And acetaminophen PRN. PRN means as needed. He has remained afebrile throughout the course of his symptoms. He relates fatigue, 1 episode of hemoptysis, which means coughing up blood, and joint pain. But he denies any chest pain and denies any myalgias, which means muscle aches. He smokes 1 pack per day for 33 years. So that would be a 33 pack year history, but does not drink alcohol. No significant family history, including cancer. So my first question for you guys is his weight loss significant? If you remember way back, I think it was when I talked about leukemias. If anybody was there for that virtual round session, I talked about what a significant weight loss amount is. Does anybody remember that, or does anybody know that? 30% is a little bit high. What we say, so it is 6 months that we look at. So we say 6 months, we want to look at 5% of total body weight. Yeah, you guys are getting closer. Maybe I should have let you get down to the percentage. But what we say is 6 months. So you guys were right about the 6 months. So great with that. And what we say is 5%. So we say 5% of the total body weight in 6 months. So some math whiz out there, tell me, is this significant? Has he lost, 5% or greater of his body weight in the last 6 months? So we know that he has a 2-month history. And he's lost 15 pounds, and his original weight was 180. So is this significant? Is it not significant? Yeah, it's significant. So basically, if you're not a math whiz and you're a science whiz exclusively, all you have to do is calculate 180 times 0.05. That's going to tell you that he has certainly lost over what is 5% of his ideal body weight. Okay. My next question, which also has to do with math, so I'm sorry to bombard you with all these math questions at, whatever time it is, wherever you guys are, is how do you calculate a pack year history? Does anybody know? That's okay if you guys don't. So the way we calculate a pack year history is how much you smoke. It always takes me forever to write this because I'm writing on a trackpad. So how much you smoke times the time. So I'll put the little t, like you guys remember from physics and calculus and whatever else you took. So how much you smoke times the time. So this one is pretty easy. I set it up, very easy for you to visualize. So he smokes 1 pack per day. So that's what PPD means. 1 pack per day, for 33 years, okay? So that's how we get the 33 pack year history. Now, what if I told you he smoked 2 packs per day for 30 years? What is that? Yeah, good job. Yeah, great job, guys. That wasn't a super hard one. So I'm glad you guys got it. And that's how we calculate pack year history. And a lot of times, if you guys are medical scribes or if you're not or whatever, you may read this in the medical documentation. And you're like, what is a pack year history? So that's exactly what that is. Okay. So enough math for one evening, hopefully. Other questions I have for you guys. What questions do we want to ask this guy? What questions do we want to ask the family about what's going on? What do you guys think? What questions should we ask? And you can ask anything broad, because really, to take an extensive history, we're going to have to ask them broad questions. Family history, sure. Yeah. What do you want to know about the family history? You're going to find, Matthew, that when you ask, do you have any family history, they're 90% of the time going to ask you, like, what? And then you're going to say, well, like, what do you want to know? We asked about cancer. They said that there was no history of cancer in the family. So we know that part. What else do we want to know about their family? Anybody else? What other questions do we want to ask? Or what differential diagnoses do we want to put on our radar right now? We say, okay, it could be this. His symptoms fit this. Any other lung-related diseases? Yeah, good job. I think that that's absolutely right. And we can pinpoint, perhaps you guys are COPD masters now, since Alexa taught you last week about COPD. So you can certainly ask, do you have a history of COPD? Do you have a history of asthma? Do you have any problems with your lungs? Good. Any other questions we want to ask, or what differential diagnoses are we considering at this point? Think broadly. We know that this guy has shortness of breath. We know that he is coughing up blood. What are we considering? What are we thinking about? Think lung-related things, think anything right now. We want to keep it broad so that we can narrow it down in order to get the correct diagnosis. Okay.
Could we also ask, like, if they've been sick recently, or if they've had, like any pulmonary infections?
Yes, exactly. Yeah, we can absolutely ask that. I'm not sure who said that because it didn't show for me, but I was like, thank you, whoever this kind voices that came up. Yes, absolutely. And in the time of right now, if you're working in healthcare or if you're not, whatever, you always want to ask now, have you been exposed to anybody with, COVID? If somebody comes in with shortness of breath, now everybody's thinking COVID. You sneeze funny, COVID. That's certainly something we can consider if they've had any other infections, because what we see is if somebody has a viral pneumonia like COVID, we could get a superimposed bacterial infection on top of that can lead to some of these symptoms. So yes, you're absolutely right. Anybody else, any other diagnoses that we want to consider? Just to kind of, COPD, upper respiratory infection, GI bleed. Sure. Yeah. Good job with the coughing. That's exactly right. Good. Anything else? He's lost weight. Anybody with the weight loss? Whenever you hear weight loss, what do you think? Fatigue and weight loss are pretty common for what I'm getting at. Yeah, cancer. Good. I was hoping you guys would, autoimmune, exactly. We could say autoimmune as well. Lupus, certain autoimmune diseases, especially rheumatoid arthritis with the joints. We know that presents with joint pain, fatigue. Good. You guys are doing really well. HIV, yeah, good. We can always think infectious disease causes of systemic illnesses. Good. You guys are doing very well with your differential diagnosis. Okay. What elements are important from the history? If you were going to take, certain things and compile them in your thought processes right now, what things are important to remember? We talked about a couple of them already. Oop. Yeah, smoking, weight loss, 2-month cough, good. Weight loss, fatigue, shortness of breath. Good. Yeah, you guys are all right. Those are all important things to consider. There's one thing from his social history that I think is so incredibly important to focus on. Yeah, he's a smoker, and he's a pretty heavy smoker for 33 years. That's a long time. I try not to disclose my age, but that's long. 33 years of smoking is longer than I've been alive. So that's a long time of smoking in my book. I don't know what you guys consider a lot of smoking, but that's a lot. And so what we're saying is not that, okay, this guy has smoked a long time. We're saying this guy has exposed his upper respiratory tract, his lower respiratory tract to carcinogens for a consistent period of time over 33 years. That's what we're saying, okay? And good, Liz, length of symptoms, episode of hemoptysis. Exactly, good. All right, what are we pinpointing on our examination? You guys tell me, I will write it down. Let's do that. What do we want to take a look at? Yeah, lungs, sure. He has hemoptysis and shortness of breath. We want to listen to the lungs. What about the lung exam do you want to do? We're going to learn today that there's different parts of the lung exam. I know that you guys are all thinking auscultation. We're going to pull out our stethoscopes and listen. Do you guys know anything else from the lung exam? It's okay if you don't. I'll show you some tests later that we can do. Yeah, percussion, good. Yeah, percussion. Percussion kind of falls also tactile fremitus. We're going to talk about that as well, fremitus. Lung function test, yeah. That's in an acute setting. I would say PFTs, lung function tests, may not be of value, but if we were to kind of see in an outpatient or plan for procedures like thoracotomy or things like this, we would probably need PFTs. So it kind of depends on his presentation at the time. Okay. Oxygen saturation, absolutely, good. That is absolutely part of the exam, so we'll say O2 sat. Anything else? We'll listen to his heart. Like a bronchoalveolar lavage, is that what you're referring to? Cool, yeah. So we'll see depending on what his other tests, but that's something that we can consider in terms of testing as well. So good, you guys have a good kind of physical exam here. So I'm going to show you some physical exam findings here. And I didn't write it in, but I'll tell you. Let's say this guy is O2 sat. His O2 sat is 80, we'll say 91%. Let's say that, okay? So he is afebrile, like he told us. He hasn't had a fever, which is good news. I'm gonna use green. I feel like I haven't used green since I've done virtual rounds, so I'm gonna use that. All right, so his temperature is 98.2. He's afebrile. He's tachycardic, normotensive. Respiratory rate is fairly normal. He is well-groomed and cachectic appearing. What does cachectic mean? For those of you smart medical terminology people out there, what does cachectic mean? Yeah, it means thin. Yeah, it means that they have muscle wasting, atrophy. That kind of goes along with this temporal muscle wasting. So kind of here where your temporalis muscle is, you've kind of lost that due to atrophy. Okay, we see that the patient has moist mucous membrane, so they're not dehydrated, tachycardic, but regular rate. Diffuse rales. So rales means crackles. And when we say rhonchi, the word rhonchi, that's kind of like snoring. Wheezes, I showed you wheezes a couple weeks ago when we talked about COPD. Wheezes, it sounds exactly like what the word spells out. And you kind of hear that in asthma, and it can be, in inspiratory or expiratory phase. And then what we see is decreased tactile fremitus in the right upper lobe of the lung. So this guy up here is doing a lung exam. This is part, so somebody out there who's very wise said percussion. So when we percuss, we use our digit and we kind of tap on it to hear the transmitted sounds. And so this is pretty similar when you put your hands on the patient's back. And what should normally happen is you should be able to transmit sounds that the patient says. So usually we'll ask them to say something like 99. And so when they say 99, you should feel it. And when there's areas of consolidation, whether that's fluid, whether that's pneumonia, whether that's a mass, whether that's whatever, interfering with that transmission of that spoken sound, that tells us that there's something going on. There's a consolidation, okay? Then what is this called down here? What are they trying to show you here? Clubbing, yeah. Good, so that's clubbing. And what does clubbing tell us, Madeline, do you know? Or what is it indicative of? How about that? That's okay. You found the sign. That's half the battle there. Clubbing tells us that there is a pulmonary problem going on. Okay, so it kind of points us in that direction. This patient also has kyphosis, thoracic kyphosis. So you see, we know that here is our cervical vertebrae, here's thoracic, and then down here is lumbar. And we see here, there's kind of this kyphosis here. When we talk about scoliosis, that's kind of an abnormal curve, like in that regard, if we're looking at it anterior to posterior. Kyphosis is kind of this, curvature in the thoracic spine. Is this significant? Maybe, maybe not. Sometimes if you do have problems musculoskeletally, if you'll remember from my talk about obstructive and restrictive lung disease, problems with your body mechanics in terms of kyphosis, scoliosis, things like this can impinge on your respirations. But is this significant to what he's having now? It's probably not causing his hemoptysis and his weight loss. So it's hard to discern if this is, compounding the issue or not at this point. Okay. Alrighty. So let's keep it moving here. Let's see. So his CMP, fairly unremarkable. His sodium's okay, potassium looks okay, glucose is okay. We see that his ESR is a little bit high, and his calcium is high. And those of you that have taken, perhaps anatomy and physiology, who have taken maybe, chemistry or biochemistry, what hormone regulates calcium hemostasis? Do you remember? There's actually two. I'm looking for one. So calcitonin is one of them. There's one more. It's released from the parathyroid glands. Do you guys know that one? I mean, calcitonin is also released from this similar area. Oh, somebody said it already before before Matthew had said calcitonin. Good, yeah, it's PTH. And so the way I remember it, there's a little drawing here. PTH regulates multiple things in the kidney. It also regulates in the bone. So the way I think of it is, when calcium gets low, the body releases PTH from the parathyroid gland that tells the bone, hey, we need some more calcium to keep it regulated, because we know if calcium is either too high or too low, this can lead to fatal arrhythmia. So the body likes to keep that in tight control, and we like to keep that in tight control in medicine as well. So in addition to that, when PTH, obviously stimulates the bone to increase or to decrease. So if the calcium is high, it decreases bone resorption. If it is low, it increases bone resorption to have it go into the blood. All right. And then PTH also, if it is high, it'll tell the kidney, look, we don't need any more calcium, don't resorb anymore. Okay. Whereas if it's low, it'll tell the kidney, hey, we need more calcium, keep resorbing it back. So that's the primary mechanism through which PTH acts. The way I remember calcitonin is calcitone down. It'll tone down calcium. Okay. So it'll work on a similar set of organs. It'll work on the kidney, it'll work on the bone, and it'll work on the small intestine to decrease kidney reabsorption, to decrease bone resorption, and to decrease small intestine reabsorption of calcium as well. That's a little bit about calcium resorption. All right, so we see here that the patient has an anemia. The patient's white count is a little bit high, it's borderline, so that's okay. And then we also see that the hemoglobin and hematocrit are low. Anybody that was there for the anemia lecture long ago, I think that was in March, and I do have a slide for you, so we're going to talk about that briefly. But what kind of anemia is this, if you guys remember? I've given you the MCV there, so what kind of anemia is this? So for the anemias, if you guys weren't here from March, long ago, when we talk about anemias, what we talk about is the MCV. So we know that our patient's MCV is 62. So we'll write that here and kind of keep that in mind. All right, so when we delineate anemias, we remember that we break them up by MCV. So normocytic, meaning a normal MCV, is 80 to 100, okay? And then if it's greater than 100, we call that macrocytic, macro meaning big. So we see big cells. If it's less than 80, we call that microcytic. So little tiny cells based on what's normal. Okay, and based on this now that we kind of see this flow chart here, what kind of anemia do we have?
Hemolytic anemia?
So we have that's a good guess, and we certainly could have a hemolytic anemia that is micro, but we do have a microcytic anemia. It is a great guess. So here is our MCV, 62, and we know that based on that, we fall into this category, this microcytic. Somebody out there said anemia of chronic disease. What makes you say that? What's this chronic disease process? Yeah, so I mean, yes, he could certainly, maybe have lead poisoning, sure, we haven't ruled out a thalassemia, but maybe he's iron deficient late in his course. All of these things are to take into consideration, yes, but most likely he probably is anemia of chronic disease. So I wanted to throw that in so you guys have a little bit of exposure to anemia tonight as well. All right, so here's our imaging. Somebody show me on this, pull out the annotate and show me on this one here, this X-ray to the upper left. Show me what is abnormal on this X-ray. Nice, Madeline was ready, and it even showed your name for me. That good. And based on this, I know I recognize Madeline's name from when I talked about COPD. I talked about restricted and obstructive lung diseases. Do you guys remember what I said in terms of what kind of delineates a chest X-ray, an AP chest X-ray from a normal chest X-ray for someone of whom has COPD? This guy definitely has it. So he is a smoker, so we know that, you know, likely he probably does have COPD as well. Do you guys remember that? So what is our, do you remember our ABCDE? What does our D stand for? Yeah, good. Is it the rib spacing and diaphragm? So it's diaphragm, yes, absolutely. We're looking at the diaphragm here, that's the D. And what we see is that we see a lot of ribs here. So you're absolutely right about the ribs. And we see that as a result, the diaphragm's kind of depressed. And do you remember, does this kind of ring any bells about this skinny cardiac silhouette here? That's what we kind of see. The cardiac silhouette is you know, pretty skinny. And if you look over to this X-ray over here to the right, this is normal. This is a normal chest X-ray, and a really good one. When I saw it, I was like, ooh, pretty. But what we see here is, you know, the heart, you know, isn't taking up, or it isn't as skinny as, you know, it is on the image to the left. And you know, you can use the one on the right as kind of a reference in terms of your, you know, your anatomy, because when we look up here, we know that the left atrium's up here, and we know that the left ventricle is down here. We know that the right atrium is, you know, over here. And then we know that the correspondingly the right ventricle is here. Okay. And then keep in mind, you know, in X-rays, you want to look for this costophrenic angle here and make sure it's not blunted. There's no fluid or anything like that. All right. And what is this? Is that normal? Anybody else? We have a guess for spleen. Anyone, any ideas? So keep in mind that this is a, we know that this is a AP film, and it's an upright film. Yeah, it's just gas bubble in the stomach. So we know that if it's an AP, it's shot from anterior to posterior. The radiation goes through. And if the patient's upright, gas rises. So that's just a gas bubble. Okay, so don't get thrown off by that. That's, you know, a fairly common finding. And then obviously we know that we have a mass here. And as someone pointed out, as Madeline pointed out, we have a what looks like a rather peripheral mass here. Okay, so because we are not radiologists ourselves, we asked our friendly radiologist to read it. This is what they called it. They called it a 7.4 centimeter mass. It's irregular, and it's in the right upper lobe of the lung. Okay. There's presence of suspicious right-sided mediastinal lymphadenopathy and necrosis, evidence of invasion into the pleura, and then the radiologist told us to correlate this clinically. Okay, and this was different from previous chest X-ray on 6/5 of 21. So we're now in September. So that was about 3 months ago. So that's a pretty good reference. And that's a lesson. This is a big reference for you to say, okay, was this on the last chest x-ray? When was his last normal chest x-ray? So that we can see kind of, you know, an important point, which is what? If he didn't have this 3 months ago in June of 2021, what does that mean for this 7.4 centimeter mass that's now in his right upper lobe? Also for his symptoms as well, his symptoms, you know, kind of onset within, you know, 2 months or so. What does it mean for this? Don't think too hard about it. I know you guys know. Yeah, it developed pretty quickly. Yeah. So we know 3 months ago his chest x-ray was normal. And now, you know, we have a pretty blatantly abnormal chest x-ray and lung CT. Okay. All right, so here's some anatomy for you in case you were dying for it. I like to include it in here now so that we don't forget about it. So here's, you know, some anatomy models, chests, and they drew on top of the chest where the lung fields are. We can kind of correlate them to this model over here. So we know that the right lung has 3 lobes while the left has 2. So we'll start there, okay? Right 3, left 2. All right, so in the right, there's a right upper, there's a right middle, and a right lower, okay? And that's what we see here. We see a right upper, right middle, right lower. Somebody who has their annotate tool out, draw where you think, based on the chest x-ray, where this man's lung tumor would be. Yeah, good. In the right upper, exactly. Yeah, Matthew was quick with his annotate key. Good, and I agree with that. You know, maybe a little bit more peripheral based on the chest x-ray, but I agree with you, it's in the right upper for sure. Good. Good. And then we see here, based on the ribs, kind of where the delineation of the lungs falls based on the ribs, okay? So there's a little bit of a quick anatomy lesson for you. All right, so we got a lung biopsy, which showed moderately differentiated squamous cell carcinoma of the lung. And you're probably like, yeah, great, what does that mean? What we see here is, yes, there are different types of cancers, lung cancers, that is. And what we're seeing here is this pattern that's pretty characteristic for squamous cell carcinoma. We call that, an diffuse keratin inside of the biopsy. That's what all this pink stuff is. And I know that I've shown you biopsies in the past that kind of look similar. This is keratin, whereas I've shown you stuff in the past that shows amyloid. So it does kind of look similar histologically. But what we're doing is we're taking a biopsy of this patient. So what you see here on the left, or I'm sorry, the right, and I'm going to show you a video of this here in a moment as well. We see the patient's kind of positioned over the CT scanner and draped accordingly, and we get a needle. And what we're doing, stereotactic means image guided. So we're using imaging in order to see where the tumor is so that we can get a biopsy. We're taking a biopsy of it, we're staining it, and then we're looking at it under the microscope. And when our friendly neighborhood pathologist looks at this, they tell us, okay, this is what we found. Moderately differentiated squamous cell carcinoma of the lung. And what we kind of are looking at is whether it's well differentiated, poorly differentiated, or, you know, moderately differentiated, which is what we're seeing here. If you guys had to guess, which would you say was probably worse? Well differentiated, poorly differentiated, what do you think? Yeah, good. You guys are spot on, and you're using critical thinking and educated guesses, which is perfect. Poorly differentiated is bad, because what we know is if, you know, we have a cancer in, you know, a section of tissue, what we know is if it's poorly differentiated and it's kind of growing all over the place, that's bad. That means it's, you know, not in the section. Whereas, you know, here, if it's kind of, you know, like this, and it's growing in the spot, you know, we have a better chance of focal treatments for that, which is better if it's well differentiated. Okay, so down in the bottom right hand, there's a kind of CT guided placement of a biopsy here. But let me show you a quick little video here. And as we kind of go on to that, why do you guys think a CT guided biopsy is important for something like this? Anyone have any ideas? Based off the location, why is it important? So think about your anatomy, we know. Yeah, so that we don't puncture the lungs, absolutely. And for the reason that when you breathe, what's going to happen to the tumor? It moves, yeah, exactly. So I want you to think about that critically, because when you understand certain principles like that, you understand why things are done. So I'm a big proponent for, understanding things and making connections and not just memorizing things. So when you think of things like this, they make sense. Okay, so here's kind of a brief little video. It looks rather outdated. When I watched it, I was like, her hairstyle is like totally from the 90s. But at any rate, here is here, let me find the part that it shows. So what we're seeing here, and this is exactly what's showing, as the diaphragm moves up and down, we kind of see that the tumor is moving. And so what we see is like, this is like hitting a moving target, literally. So imagine, you're, trying to shoot archery, at a target that's moving left and right. So what we do is we place a device on the patient that shows inspiration and expiration. So that way we're able to track when the tumor is moving, so that we're able to pinpoint that mass without causing any damage to the patient, okay? So that's the short and fast about that. Other things that we might want to consider are things like PET. So we see, based on the metabolic activity of the tissues, we inject a radio tracer and look for photon emission, and that's what we're seeing here. Areas of increased photon emission, increased metabolic activity are going to light up more. We see kind of, maybe a lymph node here. Other tests that we can include or, consider if needed are thoracoscopy, and then also thoracotomy. So thoracoscopy meaning looking at, the pleura with a camera, and thoracotomy is actually, a surgery if needed. But, we'll kind of keep those in our tool bag right now. So team, differential diagnosis right now. What do we think this guy has, other than the fact that we know what this guy has because we got a biopsy? So what does he have? Tell me what his diagnosis is. Yeah, squamous cell carcinoma of the lung. Perfect. Good, exactly. He has squamous cell carcinoma of the lung. So we say, okay, he has a lung mass, squamous cell carcinoma, okay? Other benign considerations, just because I threw this in for completeness sake, we know that this isn't a benign tumor, but we can consider things like carcinoid tumor, hamartoma, fibroma. Those are different types of benign tumors. So when you hear, a clinician say, they have a lung nodule, it's fairly small, that wasn't on their last chest x-ray, or it was on their last chest x-ray, but it hasn't grown inside, so we'll continue to monitor it. It might be one of those things. Okay, we can consider things like tuberculosis, lung abscesses, and tuberculosis is always a consideration. If somebody has hemoptysis and night sweats, and maybe is an immigrant traveling from somewhere where tuberculosis may be prominent. We can consider a lung metastasis. Somebody out there who's very wise, because I know you all are very wise, tell me why a lung met is less likely the cause of this patient's lung mass in this instance. Does the tumor number tell you anything? Yeah, it is a primary, secondary, not, or a primary cancer, not a secondary, absolutely. And the reason that that kind of, we're thinking it's more of a primary is because, yes, we got a biopsy that says it's squamous cell carcinoma, but it's likely a primary because there's one. If there were multiple, we would say it's more likely metastases. If it were a brain tumor, the most common cause of a brain tumor is what? Don't think too hard. I was just talking about, metastases. Yeah. The most common cause of a brain tumor is metastases. Granted, there are other primary causes of brain cancers, but they are less common than metastases from other primary cancers. Okay. Other things we can consider, but are less likely, are pneumonia. We don't really see that on our, chest X-ray. A pleural effusion. You can consider a, pneumothorax. These are all, underwhelming. We didn't see these things on our chest X-ray, but things to keep in mind. Okay, so this image in the upper right-hand corner, what am I showing you? So out of these three here, if you guys have your annotate tools out, tell me which one you think it is. Out of these, actually these four. Which one do you think it is? You can place a, a stamp or whatever vote by which you think this is. Yeah, so somebody said pneumonia, exactly. So where would we, and what kind of tips us off to this, that this is a pneumonia, is that it kind of, follows, some of the fissures. So we know that, okay, there's a consolidation there. Good. So let me show you another chest X-ray, and you guys let me know what do you think this is? So we remember from what I just told you, because you guys listen to everything that I say throughout this hour. I told you to look at the costophrenic angles. And we know that if we look here, okay, we can see part of it here, which is, good. We look at this, maybe the costophrenic angle would be here, but we don't really see it here. Somebody has nicely put a little yellow arrow here. So what's going on here? What is that? Yeah, fluid in the pleural cavity. In other words, it's a pleural effusion. We have fluid there that's not supposed to be there. Do you guys know the procedure to drain that out? We call it, if we're getting it from the abdomen, a paracentesis. What do we call it if we get it from the thorax? What do we call that? Thoracentesis, exactly. Excellent, good job. One more for you. What is this? Any ideas out there? So this could be COPD. I do see the dropped lungs and the skinny heart, but that may be due to an other pathology going on. Look at the lungs. Close. We do see the bronchio. We do kind of see the lining of the bronchioles. Can anyone see what the pathology is? So look at the, we know that we look at airway. So here's the trachea, it kind of splits into the right and left main stem bronchi. We know that the patient has a good inspiratory effort. We know the diaphragm is kind of dropped. This lung is fully expanded. What's going on here? Do you guys see that now? Yeah, it's a pneumothorax. And if you are not, used to looking at chest x-rays, it's easy to kind of miss a small one of these, but always make sure and look to see that your lung is fully expanded here. That's important to look at, okay? So I wanted to show you those other chest x-rays. If I'm going to throw the, 5-cent words at you, I figured I should give you the images as well. All right, so this slide looks very overwhelming, but I'm going to briefly talk about this, and staging is always very advanced and it's cancer dependent. But if we were to stage our cancer, we remember that the patient had same-sided mediastinal lymph nodes. So let's write our findings that we have here so that we can stage this together, and we'll make a little bit of sense of it. So we know the patient had same side, which we call ipsilateral. If it was on the other side, we would call it contralateral. Mediastinal. And then we know that the tumor was 7.4 centimeters. So let's start with T. What we call this is TNM staging. So what we're doing basically is we are, sorry, let me get my pointer out here. So the T stands for tumor size. Let's start there. Based on our findings, what tumor size do we kind of fall in? If we say it's T1, it's less than 3 centimeters, T2 is 3 to 7 centimeters, T3 is greater than 7 centimeters, and T4 is invasive. That's, it's spread. Good, we have T3, excellent, good job. Everybody, good participation here. We're at 7.4, so that would kind of fall us, or, throw our cancer into this bucket for T. N is for nodes, so TN. So we know that we have same side, ipsilateral, mediastinal lymph nodes. Okay, so we have sort of lymph nodes grouped in here. It kind of draws some here too as well. But what does that mean? Good, yeah. So we have an N2, excellent. And then M stands for metastasis. What do we have for metastasis? What M classification are we? M0. Good, yeah. And based on the PET, we don't necessarily know. So somebody said that, assumably we would have had a full body PET CT or a full body MRI to evaluate for metastases. So granted that I didn't tell you, there aren't metastases, so we can assume that there's not, based on the PET scan. And then over here, it kind of, lumps it into stage based on this. And this is probably what you guys are overwhelmingly kind of used to, when you hear somebody say stage 4, stage 2, stage, whatever, but it's very complicated. And I'm sure you're going cross-eyed looking at that category or that table there. But I wanted to bring up to you that when we talk about lung cancer staging, what we do is we differentiate it into non-small cell cancer. So people will write that as non-small cell lung cancer. So NSCLC, whereas small cell is the other branch. So we say, okay, there's small cell and there's non-small cell, okay? And when we talk about small cell, we say limited versus extensive. And the reason why we delineate those two things is because the treatment is very different. For non-small cell cancer, we usually, when we talk about non-small cell, we say things like adenocarcinoma of the lung, squamous cell carcinoma of the lung, large cell, we talk about any other that is not small cell. And the reason why we separate them is because the treatment is vastly different. Okay, so for non-small cell, we usually do surgery and then adjuvant chemotherapy, which means chemotherapy after you have surgery. Whereas for small cell, usually it's so extensive when it's finally caught, and not sensitive to radiation, that usually it's we do chemotherapy for that. Okay, and you know, it's too far for surgery at that point. So we do, you know, maybe chemo radiation in that regard. All right. So we already established here that the staging here is, if it'll go, okay, non-small cell lung cancer. Based on what I just told you, how are we going to treat this guy? So we know that this is a non-small cell lung cancer. So how are we going to treat him? We know that for small cell, we don't use surgery. What are we going to do for squamous cell carcinoma? Yeah, surgery plus chemo. Good, exactly. And that's exactly what I wrote here. We're going to use chemo, radiation, surgical resection. Good. And then, you know, it's all ultimately dependent on the stage, and you might hear words like palliative radiation. You know, if this was a patient of whom, you know, the lung cancer was caught, you know, fairly advanced or very cachectic, you know, they're on hospice care, we might do something called palliative radiation to improve their quality of life while they're on hospice, you know, while they're, you know, while they get comfort care. All right. So when we talk about the pathology of, I should say, lung cancer, when we talk about the pathology of lung cancer and diagnosing it, the best test is a CT or chest X-ray. Keep that in mind. That might be a quiz question. And the way we find out what it is by using a tissue biopsy. If it's peripheral, we'll use a fine needle aspiration. We'll kind of come in from the side here using a stereotactic mechanism and pinpoint this. If the mass is more central, we might do a bronchoscopy, meaning we'll go down the trachea and with a needle kind of take a sample of that. And my good friend Matthew mentioned a bronchioalveolar lavage. We would use something like that primarily, you know, if we knew there was an infection or something. For this, we'll use a bronchoscopy and kind of take a sample of it. So it's very similar to what you had mentioned. So you were on the right track with that. We could also consider PET and MRI there. And then in addition to that, this is, you know, perhaps a little bit advanced, but I do want to bring your attention to something that I talked about here, which is the hypercalcemia. With squamous cell carcinoma, the tumor itself has the paraneoplastic syndrome, meaning it causes something else, and it produces the tumor itself. So here's the, you know, the big bad tumor. It produces something called parathyroid, so PTH. So PTH related peptide. So we call that RP, PTH related peptide. And what we see in the labs is that we have a high calcium, but we have a normal PTH because our assay doesn't look for PTH related peptide, this kind of imposter PTH. It looks for PTH itself. So when our calcium is high, it tells the parathyroids, look, we're good. We don't need any PTH to stimulate bone, you know, bone resorption and resorption from the kidney and all of those things that we talked about before. So this is the pattern that we kind of see, which is kind of, you know, peculiar to us. Also, we see in the biopsy that we see those keratin pearls and those intracellular bridges. And that's what this image here is showing of this biopsy. We kind of see those keratin pearls here, and pearls because they kind of look like pearls on a necklace. Okay. All right, and then here's all these other lung cancers here. Small cell is very, very aggressive usually, and poorly differentiated. And we also see paraneoplastic syndromes with small cell, where we have ACTH being produced that can cause Cushing syndrome, ADH that can cause you know, hyponatremia, seizures, things like that, and antibodies being produced that can cause Lambert-Eaton syndrome. But I'm gonna leave this slide for you guys to kind of look over. I kind of touched on the points that I wanted to. Remember, the way we kind of differentiate this again is by small cell and non-small cell. All right. Okay, and here's, a quick kind of cartoon that shows the malignancies that love bone. This cartoon kind of delineates it by bacon, lettuce, tomato, and kosher pickle, being that bacon is for breast, lettuce is for lung, tomato is for thyroid, and kosher is for kidney and kosher pickles for kidney and prostate. So these are the ones that love to go to bone. And this is especially true. Breast cancer loves to go to bone, but also lung cancer does as well. All right, so here's some risk factors. Here's some risk factors in terms of exposures. The number one risk factor overwhelmingly is smoking. Does this mean that non-smokers are, exempt from getting lung cancer? No, it happens. The most common cause of lung cancer in females who do not smoke is adenocarcinoma. I had a little blurb about that in the last slide. But then we also think about things like exposures. We talk about other illnesses. We talk about aging. We talk about, radon gas exposure, family history. And then things that, delineate the risk for malignancy. We look at certain things like, are they a smoker? How long did they stop smoking? And then other things in terms of, the other things in terms of, the diameter of the nodule. Keep that one in mind. That's something that we kind of, look at, whether the size is large. If the size is large, okay, it's greater than 2 centimeters, it's a high risk. We also look at their age. We look at, the nodule characteristics. If it's, spiculated, that's bad. If it's smooth, well-defined, that's probably less likely a malignancy, okay? I believe that's my last slide. So I was a little better this time. I think I was right around 60 minutes. So I appreciate your guys' time. Let me